we'll get started. Leah, is that okay with Kaz in office?
Yeah, that sounds great.
Good afternoon, everyone. My name is Noelle Patton. I'm a pharmacist from Newfoundland and Labrador, and I'll be moderating the webinar this afternoon. Before we get started, I'm going to quickly turn it over to Kaz in office. We're going to just host a short poll before we get into the webinar.
Okay, I'll end the poll, and Noelle, you can take it from here.
Great, thank you, Leah. So welcome again, everybody, and thanks for completing our short poll. This is the first webinar of a series that are part of a project on health professional education on opioid use and opioid use disorder, funded by Health Canada. I was lucky enough to participate in this committee, and that's my connection to today's webinar. This afternoon, you'll hear a bit about the project and the recently launched e-resource, which is open access and available to you. We are also pleased to welcome several guest speakers who will provide you with a current overview of opioid use and opioid use disorder in Canada, as well as look at how stigma and implicit bias affect care. We hope that throughout this next hour and a half, you'll discover a new resource that will be helpful to you in your practice or education setting and provide you with an opportunity to learn from subject matter experts. So first, I'll introduce you to Janet Cooper. She'll give a high-level. Janet is the Executive Director of the Association of Faculties of Pharmacy of Canada. That's a mouthful. She's going to give a high-level project overview. And I'll turn it over to you, Janet.
Thanks, Noelle, and welcome everybody. So I'm just going to give you a bit of a brief background from the Management Committee. So in 2018, the Association of Faculties of Pharmacy of Canada, the Canadian Association of Schools of Nursing, and the Canadian Association for Social Work Education started this project, and it was led by Kazan. We had funding support from Health Canada, and together our organizations committed to work together collaboratively to foster curricular change in education programs for registered nurses, pharmacists, and social workers across Canada. And the goal of the project is to ensure that health and social service providers enter the workforce well equipped with relevant, evidence-informed knowledge to address issues related to opioid use and opioid use disorder. And this is across the prevention, health promotion, harm reduction, treatment, and recovery continuums, and at the primary, secondary, and tertiary care levels. To achieve this goal, the project has developed a series of outputs. The first was interprofessional education guidelines related to opioids use and opioid use disorder. And the goal of the guidelines is to promote and guide curricular change in Canadian schools or faculties of nursing, pharmacy, and social work. The education guidelines were completed in early 2020 and are available online in both languages. And the second output was to develop protocols that address selected areas within the education guidelines that will facilitate integration into member schools. To date, a protocol on stigma and naloxone are available. The third, which is by far the most extensive, is an electronic resource for faculty and students in entry-level nursing, pharmacy, and social work programs. The e-resource provides our programs with information, teaching and learning materials, and tools related to the education guidelines. It provides greater and more in-depth content to foster the integration of the interprofessional guidelines into the curricula of member schools, and it even includes a section on lived experiences. Currently, as I said, the guidelines are in French, and the e-resource and protocols will be available in French later this month. The e-resource, which was linked for you in the webinar welcome email, includes a wealth of knowledge developed by numerous experts in opioid use and opioid use disorder across pharmacy, nursing, and social work. And this unique educational aspect to the project and this resource makes it usable across a wide spectrum of health and social service providers. And I hope that following the webinar, which will include a presentation on the content development, as well as some guest speakers on key topics within the area of opioid use and opioid use disorder, you'll spend some time looking through the e-resource and consider how you could use it in your curriculum, and also provide the project team with some feedback and a short survey, which will be sent to you following the webinar. So to wrap up, I just want to thank Health Canada for the funding, and I also want to thank Leah Watts and Cynthia Baker and the rest of the team at CASN for their leadership and their hard work for what I think is a very unique project, and having social work, pharmacy, and education all collaborating on something. So if you have any questions at all, please send an email to Leah Watts at CASN. It's lwatts@casn.ca. Thank you very much.
Great, thank you, Janet. Our next speaker is Dr. Michael Beasley. Dr. Beasley was the co-lead with Dr. Feng Chen on the content development for the e-resource. Dr. Beasley is an associate professor at the School of Pharmacy at the University of Waterloo. His clinical and education research is focused on the role of health professionals in reducing harms associated with problematic substance use. Dr. Beasley will provide you with an overview of the content development process.
Great, thank you very much. Can everyone see my slides? Does that look good? Oh, got some hands raised already. Where'd they go?
They might be saying they can see your slides.
Yeah, can you see them now?
Yeah.
Okay, so thanks for the introduction. I won't take too much of your time. I just want to give a sort of brief overview to the group about how we went about creating the modules and topics in the e-resource, who we were, who we are, I guess, how we went about creating the content, and just a few notes about how we dealt with issues around language and stigma and breadth and depth of the content, as well as a few notes on using the modules. So I'm Michael Beasley. I'm at the School of Pharmacy at the University of Waterloo, and my colleague Fen Chang really spearheaded pulling together this group that included the two of us, as well as Professor Colleen McMillan from the School of Social Work at Renison University College, and Professor Shelley Walkerly, who took on the bulk of some of the nursing-focused content from the Faculty of Health at York University. We had loads of supports. Huda Shah, who was the coordinator for the project, Rosemary Killeen, who's here at the School of Pharmacy, who has extensive expertise in education, and in particular online continuing education. And we couldn't have even thought of doing this without having the Center for Extended Learning from the University of Waterloo, who really have so much expertise when it comes to effective online learning modules and creation. And they really did guided us through the process, helped us understand what we could do and what we couldn't do, and made everything look really pretty at the end. So as was introduced, the advisory committee, starting in 2018 and continuing for a few years after that, really did the work of identifying the learning objectives and topics of what this project was going to cover. And they ended up with a final tally of about 65 specific objectives and topics. And so between the four of us and with help from other supports, we went about trying to develop content that addressed each of these topics sufficiently. Where necessary, we sought out external expertise to help us address gaps in content that we needed. And we went through an extensive review process within the Waterloo team at first, working with the Center for Extended Learning, with the management committee, and ultimately getting feedback from the advisory committee, as well as external stakeholders. So this is what a module looks like. So this is excuse me, 7th module of module 1. So we've got module 1, and we've got about 7 or 10 topics in each module. And topic G in module 1 is to differentiate between the types and routes of administration of opioids being used clinically and recreationally in Canada. And so each module will start off with several learning objectives. And then there's a sort of summary 5 to 8 bullet point key concepts right off the top. And you can see on the left, you can sort of navigate through all the different sections as you go through the module. Excuse me. This is an example of just one of the content pieces talking about the different prescription and over-the-counter opioids available in Canada, as well as a discussion of unregulated opioids, such as the fentanyls, the fentanyl analogs, and other synthetic unregulated opioids. And at the end of each module, there'll be 3 to 5 questions. Typically, they're multiple choice type questions, but in some cases, they are short answer format questions that the student or the user can hit the check box and see some feedback right away. So we had several challenges around language. Obviously, we know, and we'll hear later in today's session, how important stigma and the use of non-stigmatizing language is. But beyond that, we also had challenges because not all of these 3 amazing professions use language in the same way. And so pharmacy-centric resources and nursing-centric resources, social work resources may use different terminology and different language. So one of the things we've included is a glossary of some of the definitions, what we mean when we use certain words. We've also talked right at the top of that about how we've addressed languages. And for example, even talking about the person who's using the substance can differ from profession to profession. So in pharmacy, you'll see the word patient used to describe almost everybody, whereas individual person you're working with may be the language that's preferred in other professions. We also had the challenge of trying to balance breadth and depth. So we wanted to cover lots of different topics. We wanted to cover them in sufficient depth so that they're useful to the learner. But we also understood that our primary audience were undergraduate social work, nursing, and pharmacy students, and they're going to be coming from different backgrounds and have different skill sets and different knowledge bases. We also kept in mind that we're not telling educators where and when in their program to use these resources. So a specific module or topic could be used in the first week of the first term of a nursing program, or the last week of the last therapeutics course in a 4th-year pharmacy program. So we also wanted to make the topics balanced with that respect. Most of the modules and topics are about 1,000 to 2,000 words, and they're designed to be impactful to all 3 types of undergraduate students. And obviously in some topics are more centered to one profession or the other. They're also designed to be fairly accessible to other healthcare professionals and other service providers. We didn't anticipate that educators would assign the 65 topics to do for their class sequentially. I suppose you could. And so if you were to go sequentially through all of the 65 topics, what you would see is a fair amount of repetition. And so because we had anticipated that most educators would assign different modules and topics kind of a la carte to serve their needs, we did endeavor to make sure key data and key content was reproduced to some extent or another across several of the topics and modules. I'm happy to answer a few burning questions. I'm also happy to stick around in the chat during the session to answer questions you might have there as well. Thanks so much.
Great, thank you, Dr. Beasley. I'm not seeing any questions in our Q&A field right now, but we'll keep an eye to that. And thank you for sticking around to answer any questions as we move along. Okay, our next speaker is Tara Gomez, a scientist in the Li Ka-shing Knowledge Institute of St. Michael's Hospital, an assistant professor at the University of Toronto, and she holds a Tier 2 Canada Research Chair in Drug Policy Research and Evaluation. Her research is focused on drug safety and drug policy, and she works with people who use drugs, clinicians, and government regulators at all levels to develop evidence to inform and evaluate policies and programs related to opioid use disorder and opioid-related harm through the Ontario Opioid Drug Observatory. So I'll hand it over to you, Tara.
Great, thank you. Can everyone see my slides okay? I'll assume yes, unless I get a chat telling me otherwise. So yeah, thank you so much for inviting me here today, and really happy to speak a little bit about some of our understanding of, in particular, how the current COVID-19 pandemic has been impacting the situation that we have been facing around opioid use, and in particular opioid-related harm across Canada. I am a researcher based out of Ontario, so you'll probably see a lot of the content of this presentation is focused on Ontario, but I've also tried to draw some examples from elsewhere in Canada as well, because this is certainly an issue that is national and impacts different parts of the country differently. So if we just start off by thinking about what the kind of state of opioid-related harm, and in particular opioid toxicity deaths in Canada, has been prior to the pandemic. We really only started collecting this data in 2016 at the national level. But since that time, we did see some rises, largely because of increasing unregulated fentanyl that was in that illicit drug supply throughout 2017 and 2018. But we came to this state of having about 4,000 opioid-related deaths across Canada just before the pandemic. And one of the things that myself and many of my colleagues were concerned about when the pandemic arrived in Canada was what that intersection was going to look like with the ongoing overdose crisis that we have been dealing with. And in particular, there are a number of different concerns that we had related to the fact that the way in which borders and travel and movement of goods were changing, and how that could interrupt the drug supply and lead it to be much more unpredictable, which can be very dangerous when people use drugs. A lot of concerns around changes in accessibility, particularly early in the first wave, in terms of community-based programs and supports like harm reduction services, safe spaces to use drugs. And because of lack of PPE and inability to rapidly adapt some of those services to the context of the pandemic, despite best efforts, there were interruptions and gaps in access to some of those services, and that was a real concern for many people. We also know that we all experience disruptions in access to healthcare providers, including both pharmacists and primary care providers and other specialists. And there was this big transition that we've now faced into virtual healthcare. For many people who use drugs, sometimes that transition is more challenging if they don't have access to telephones and computers to access that care. But also we know that among people who are getting treatment for a substance use disorder like methadone or Suboxone, it relies heavily on very frequent engagement with a physician and a pharmacist, often daily with a pharmacist. And so there's a real concern about what might happen with changes in accessibility to these services. And then finally, we've all known for a long time now that one of the main public health responses to the pandemic is a focus on physical distancing and isolation in many cases. And while that can be very beneficial at preventing the spread of COVID-19, we were very aware that that could have really devastating impacts among people who use drugs, who often heavily rely on their communities of support and on using drugs around other people so that they could have somebody there to intervene in case of an overdose. So as all of these things were coming together, there was a real concern among the clinical community, the harm reduction community, about what this pandemic was going to mean for the ongoing overdose crisis. One of the things that came out very quickly in Ontario and was a real benefit was that there was very rapid change in guidance around OAT, sorry, excuse me, and in particular, a change in guidance around take-home doses. And so, as I mentioned before, most people who get methadone get daily dispensed methadone from the pharmacy. And so there was a rapid shift towards suggesting that many people who previously would not have been eligible for take-home doses would start to be able to access more frequent take-home doses, often up to 1 or 2 weeks of methadone. And so one of the things we've been looking at is how that actually resulted in any sort of change in clinical practice. And what we've seen, you can kind of see the vertical line that represents COVID in this figure. And these are different levels of take-home doses for methadone. And we saw very quickly in Ontario a shift towards much less frequent occurrence of people having daily dispensed methadone and increases in longer take-home doses for methadone. And when we look at Suboxone or buprenorphine, we see similar changes with even longer take-home doses. So many people getting 14 or even 28 days of buprenorphine to take home. So one of the positive things that we saw in the pandemic was this rapid response in terms of providing that guidance to clinicians and clinicians rolling that guidance out. We've been trying to monitor what it looks like in terms of adherence to OAT, trying to understand if there were these gaps in access to treatment that we were really concerned about. And this figure just shows the percentage of people discontinuing therapy over time. And one of the really reassuring things we saw here was that there doesn't appear to have been, any sort of even short-term dramatic reduction dramatic increase in people discontinuing therapy. So that was certainly helpful to see. We're also doing follow-up work, then seeing, whether there were any risks associated with these longer take-home doses, and the preliminary findings of that work also suggest that there was no sign of increased risk of overdoses, and in fact, this pattern of lower risk of discontinuation for people who got longer take-home doses persisted. So I think, this is just one example of a real positive shift that we saw in the pandemic of people really being proactive and trying to help support people who use drugs and make sure that they were able to maintain their treatment. If we go back to this figure, though, of opioid-related deaths across Canada and extend it out to see what's happened during the pandemic, what we see, however, despite these efforts that were made around treatment for substance use disorder, is that there was an immediate and rapid rise in the rate of opioid-related deaths across the country. And when we look across Canada, there is variation. So there's always been variation even before COVID-19 in terms of the rates of opioid-related deaths by province, with Ontario, BC, and Alberta often having the highest rates. But we've seen throughout the pandemic that has even continued to worsen. So in 2020, there were 6,200 opioid-related deaths, with about 2,500 of those in Ontario and 1,700 in British Columbia. So you can see again how those three provinces really do make up the largest proportion of deaths, although you see opioid-related and opioid poisoning deaths happening across the country. When we delve a little bit deeper into this, some of the work that's come out of BC around the illicit drug toxicity death data does again just reinforce the fact that there was this immediate increase in opioid and illicit drug toxicity deaths within the province. And in this figure, it's stratified by sex. You can also see that happened more predominantly among men compared to women. And some similar work that we have done in Ontario, where we use the coroner's investigations to really try and understand the various circumstances around deaths during the pandemic. The results were really similar, where we saw this immediate increase again in the trends of opioid-related deaths. But then again, with demographics, we see these shifts where we see a shift towards more of the opioid-related deaths occurring among men. So nearly 80% of opioid-related deaths during the pandemic were among men, and the largest absolute increases happening among those kind of younger and then middle-aged adult age ranges, so the 25 to 44 and 45 to 64-year-olds. So while shifting demographics is important, what we've been trying to do is better understand some of the other factors that have changed during the pandemic that might give us some hints as to what can be done to try and address these rising rates that we're seeing. And one of the things we've been looking at is where the overdoses are occurring. And this ties back to some of the concerns that I flagged early on about what was going to shift in the pandemic. And while we know that the majority, so nearly 3/4 of overdose deaths do occur within private residences, what we saw during the pandemic, and just to orient you to these figures, the yellow line is the line that represents what happened in the first year of the pandemic compared to the year prior, which is the blue line. And you can see that there was just this general shift towards more opioid-related deaths happening either outdoors or in some kind of supportive housing setting, be it a shelter or a rooming house or a hotel. And specifically, when we delve further into the hotel data, these deaths occurring within hotels were predominantly among hotels that were being set up in Ontario to provide supportive housing and isolation for people experiencing homelessness during the pandemic. So there was this general shift that we were seeing towards these toxicity deaths really happening within some of these settings that were really being set up to support people who were vulnerably housed. And this ties into then looking at the housing status of people who experienced these fatal overdoses during the pandemic. And again, while the majority of people do reside in private dwellings, we saw a significant increase in the proportion of opioid-related deaths that occurred among people experiencing homelessness. And so we wanted to investigate that a little bit further. And when we look further, during the pandemic, what we've seen among this specific population of people experiencing homelessness is that about 1 in 6 of all of the fatal overdoses that happened were within this population, and the absolute number of deaths in this population more than doubled to 323 deaths during the pandemic. So in Ontario, there were 323 opioid overdose related deaths in the first year of the pandemic among people experiencing homelessness. So really large numbers of deaths that we're seeing in this population. And importantly, when we look at whether some of these people within this population are living within supportive housing and hotels, we see that there's a relatively high proportion of that as well. And this really just reinforces the fact that there's a need for us to think about how we provide services, be it harm reduction or safe spaces, other safe spaces to use drugs, supervised consumption services, and trained people to administer naloxone within some of these settings that are meant to support people who are experiencing homelessness, but can sometimes be putting them at greater risk of having a fatal overdose. When we think too about the drug supply, one of the patterns we've really seen across Canada, and in particular where it's monitored in British Columbia, Alberta, and Ontario more rigorously, is this real shift towards fentanyl being the driving factor behind opioid-related deaths. And in the pandemic, that has become even more so. Nearly 90% of the opioid-related deaths involve fentanyl, and that's not prescription fentanyl, that's the unregulated fentanyl. And the number's almost exactly the same in British Columbia, where they also monitor this. So this is something that is really predominantly an issue of the unregulated drug supply now. We do still see some prescription opioids, you can see in this figure, that continue to play a role in toxicity deaths, but certainly fentanyl is the predominant issue that we're grappling with right now in the overdose epidemic. What's really, I think, important to think about as well, though, is that there have been really, really considerable shifts in other drug involvement in these overdoses that have occurred during the pandemic. And one of the ones that stands out the most is the role of benzodiazepines. So prior to the pandemic, just less than a third of opioid-related deaths involved a benzodiazepine, and those were predominantly prescription benzos. But what we've seen during the pandemic is now half of opioid-related deaths are involving benzodiazepines, and a large component of that is unregulated benzodiazepines. So drugs that are not regulated for sale in Canada, and in particular a drug called atizolam, although fluoprazolam and flubbermazolam are also showing up in the unregulated drug supply. And this is really something that we are seeing in drug checking services, where the drug supply is being contaminated with these benzodiazepines. So people who think that they are buying fentanyl or other opioids are actually getting drugs that have fentanyl, as well as large amounts of benzodiazepines in that supply as well. And that can have really important impacts on the experience of people who use the drugs, as well as the ability for people to resuscitate them, because naloxone will not work on the benzodiazepine component. And it just complicates that overdose response even more. We also have seen shifts in stimulant involvement, so a shift towards much more involvement of cocaine and methamphetamine in overdose deaths during the pandemic. And when we speak with people with lived experience and harm reduction workers, the thought is that this is not because of a contamination of either drug supply with the other drug, but actually that the way in which people are using drugs is changing during the pandemic. People are much more often using stimulants as well as opioids in many cases to counteract the sedating effects of the benzodiazepines that are now in the drug supply. So you can kind of see how all of these things have a domino effect where you get benzos in the supply and then people start also using stimulants to counteract that. And it can become very complicated and a really dangerous mix of drugs for people to be using. So just in closing, our group, as well as many other groups across the country, have been really trying to figure out what we can learn from what's happened so far during the pandemic and how we can try and improve the response to try and keep people safe. I think, the positive thing that we can speak to is the fact that there was really rapid clinical change related to OAT. And I think that was really beneficial for many people who were in treatment for an opioid use disorder. But despite that, we continue to see really large increases in opioid-related deaths because not everybody with an opioid use disorder or who uses drugs is going to want to enter into a treatment program or is going to have had success with those programs. And so we have to also think about that population and how we support them. And, I've spoken about some of the factors related to these increases relating to the unpredictability of the drug supply, which we can very clearly see in postmortem toxicology, changing access to supervised consumption services and other harm reduction services, that isolation, as well as just the different ways in which people are using substances, like that increase in stimulant use. I also think it's important to point out the number of deaths that we have seen in hotels that have been repurposed as shelters, because that was really designed to be a way to support people during the pandemic who were vulnerably housed and provide them with safe spaces. And what we continue to see is those safe spaces are not as safe as they were meant to be for people who use drugs, and that there really needs to be a focus when setting up shelters and other isolation sites for thinking about how you build in the services that people will need to also make sure that they can access the harm reduction tools that they need. And then finally, the impacts are broad. As I mentioned, most of my work is in Ontario, but it's amazing how much this work parallels what is coming out of British Columbia and even Alberta, and with each province having different responses and different approaches. I think we will likely start to see different trajectories as we move forward as well. So in terms of what I think we need to be thinking about in this space, I think that we need to be thinking about kind of investments in terms of improving access to safe spaces to use drugs. For many people on this call who might be more involved on the treatment side of things, thinking about making sure we have low barrier access to treatment, as well as safer drug supplies for people among whom treatment is not working for them or is not the best option for them. Thinking about integrating these services into different temporary housing options and shelters that exist to make sure, as I mentioned before, that people have the support that they need where they need it. And those are all kind of reactive, honestly. They are just trying to kind of quell the huge numbers of opioid-related deaths that we are seeing right now. But I think we also need to consider more upstream policies and decisions. And these are longer conversations and more complicated than we could get to in something like this, but thinking about, housing and how housing status can have huge implications in terms of risk and supporting people who use drugs and helping them have some stability that can really improve their outcomes, as well as thinking about models for decriminalization of drug use. And making sure that those conversations, when they happen around those models, are integrating the perspectives of people with lived experience who can really best explain what kinds of models would work best for them. So I think I'm going to stop there and pass it back. And I think we have a little bit of time for questions if there are any questions.
Great, thank you, Tara. And we do have about 10 minutes for questions, so certainly encourage people to send along their questions through the Q&A function, and I'm sure Tara would be happy to address them.
I see a question about why there was no data on deaths in Manitoba. In terms of the presentation, it's mainly because I don't, that's not data that I have great access to. In terms of the figure of opioid related deaths across the country, I think you might have noticed that Manitoba has a big not applicable to it. I don't know the full details of that, but I believe that, so the way that this data all came about was a lot of the coroners came together and came up with a consistent definition of what an opioid related death would be across the country, and a way in which they would report that up to PHAC so that they could report it on the national level. My guess based of this is that Manitoba has not participated in that process, but I can't say for certain, to be honest. Yeah, and somebody had commented that they think it's because Manitoba's court is under justice and not the health, and that could certainly be it, because I know there have been real challenges in sharing data and some of the difficulties in terms of, you know, the sensitivity of the data, and so if it's under a different jurisdiction, that could definitely complicate that.
There was a question to share your slides. This webinar is being recorded, but I'm not sure if sharing the slides is something you're willing to do, or
yeah, I'd be happy to. I'll have to just take out some of the OAT work that's just not published yet, so I can't share those slides broadly right now, but I can certainly share the rest. And all of the OAT work is really close to submission, so hopefully in the next few months that will be public as well.
Great, thank you.
Tara, there's a second question typed into the Q&A.
About Quebec as well, not providing clear data on deaths directly related to opioids. I also honestly don't know the answer to that. It's complicated, and I think even the different coroner systems are quite varied across the province. So it could be partially related to that. I know there have been other issues or challenges, I would say, in accessing other data from Quebec related to some of the opioid work. I think that there are just different decisions around how data will be shared often that comes out of Quebec. So I'm sorry, I don't have the full details of those decisions that each province has made around the sharing of their data, but I do know that it is complicated, and there are likely jurisdictional restrictions that are making it more challenging for them to share the data.
Great, thank you again, Tara. It doesn't look like there's any further questions coming in, so we'll move on to our next speaker. Dr. Avid Zukera is the incoming chair of psychiatry at the Institute of the Living and chief of psychiatry at Hartford Hospital under the Hartford Healthcare Behavioral Health Network. He joins Hartford Healthcare from London, where he served as associate professor of psychiatry and pediatrics at the Schulich School of Medicine and Dentistry at Western University, and provided clinical consultation to the Child and Adolescent Mental Health Care Program and the Pediatric Chronic Pain Program at London Health Sciences Centre. He was also a scientist at the Centre for Education Research and Innovation and an associate scientist at Children's Health Research Institute / Lawson Health Research Institute, and served on the executive committee of Western Center for Research on Health Equity and Social Inclusion. Since 2012, he has secured over $2 million in grant funding, including several peer-reviewed research grants as principal investigator. His research program focuses on bias, equity, and stigma in health professions education. So I'll hand it over now to Dr. Zukera.
Thank you so much for the kind introduction. Can everybody hear me okay?
Yeah.
Awesome. So I have just a few minutes to talk to you a little bit about topics related to stigma and bias. Whenever I've presented in the last several months, I always pause before I present to acknowledge that We're all living through a very chronic stressor. Many of us are hurting, many of us are facing a scary and uncertain future. It's really important that we pause and honor our complex and heavy emotions, however nuanced they might be, and remember that this isn't forever, it's just right now. So I worked in an acute general hospital as a psychiatrist. And I, early in my career, was fascinated by the topic of stigma. Now, the reason for this is simply because I bore witness to the daily dehumanization and denigration of people that I worked with. I watched how people built up the courage to seek help, only to experience a significant amount of blame and shame. I also watched how many of those who perpetuated that blame and shame were people like me, people who were health professionals, who worked at the point of care, people who had high expectations of themselves and one another. I don't have time to get into details with you, but the start of this work was a journey where we focused on what we call implicit stigma, the kinds of stigmatizing attitudes and behavior that we exhibit despite our best intentions. We did a lot of work, we made a lot of gains, but when people asked me to modify or to move this into the realm of addictions, I felt like I needed to do more research. You can't just take something that's been developed in a certain context and put it as a cookie cutter into another. So as I spent time engaging with colleagues, for example, working on acute medicine units, taking care, for example, of people who inject drugs, it was very clear to me that stigma is more than just something between us or something that gets internalized. It's something that's very much structural. It's embedded, it's baked into everything we do. And as you see in this picture, it is part of our system. So this is a flag, a behavioral flag that was initiated in the hospital system. People would be screened against a non-validated tool. And if someone was screened positive for risk of violence, there would be a visual indicator on the door of their room, a scarlet letter, a label that immediately conferred certain inferences that teams would make. In our research, we observed coercive cycles between people who seek care and are struggling and people who work in the system. There's a lot of fear and uncertainty. Most staff aren't trained, nor do they feel that they have the skill and confidence to manage things outside of their comfort zone, particularly when it comes to mental health and substance use. And then there's labeling. Labels get attached explicitly, like with the flag, or implicitly. Implicitly, sometimes that these patients are unpredictable, that they might be violent. But the most poignant label that people were attaching was that this is an unfixable. And people like to feel useful, so then they checked out. They wouldn't go in the room, they would avoid. And in other research we've done, they would actually detach as a form of coping with the frustration that they were feeling for not helping people. So this leads to cycles of frustration and helplessness and fear. And we see this happening, and we see the human cost of it. So if we think about stigma, which I would say is discrimination and prejudice experienced by people with complex mental health and substance use challenges, I mentioned that it can be social, the labels that exist within us. It can be systemic, and that refers to laws and policies in terms of criminalization. But it can also be internalized, which you see at the top, which is when someone experiences such a consistent amount of blame and shame that they begin to feel that they are part of the problem. And we know that that's empirically linked with suicide. It's also empirically linked with poor treatment adherence and less help seeking. But this part of structural stigma within organizations is where we zoomed in. We did some observational research on these medicine units with hundreds of hours of field notes and observation. We learned a lot that I think has implications for you all. If we're trying to address things like interpersonal stigma or self-stigma, we can teach, we can learn, we can have education, we can challenge stereotypes. shouldn't be a one and done workshop or a box that we can check, but we can foster increased awareness, we can build skills. But when it comes to structural stigma, these kinds of biases that are embedded within the systems, embedded within the norms and values of what we do, it requires us to do a bit more deconstructing and dismantling. So what do I mean? Well, what I mean is that we can break this cycle, but the way to break the cycle is through courage. Courage is required because if norms are biased, if the norm of the way we deliver care is stigmatizing, is prejudicial and discriminatory, and we speak up and go against the norm, that requires courage because there's lots of folks that might be dedicated to preserving the status quo. But what it also requires is compassion. Compassion for others, working to see one another as unique, complex, nuanced human beings, but also compassion for ourselves. There tends to be a toxic perfectionism that affects people who work in healthcare. We build layers of armor, both literal and figurative, to protect ourselves from being human, from being vulnerable. It also requires engagement. If we know that avoidance is the problem, we have to proactively engage, change our behavior, not simply just raise awareness, enhance our confidence, and lean into challenging moments, seeking connection, recognizing that there are ways to work through some of the challenges in a much more trauma-informed way that aren't coercive, where we're seeking to take control, but rather amplify and uplift everybody. One way of looking at this is through the lens of structural competency. The work of Metzel and Hansen highlight that structural competency is a different way of viewing these kinds of issues. It requires that we recognize the structures that shape interactions, develop an extra clinical language. It requires reframing, observing, reimagining, and developing humility. So how can this be enacted in practice? Well, let's imagine someone's in rounds in a general hospital. Let's imagine that they see someone who has a history of intravenous drug use. How can they recognize how stigma is manifesting during these care processes? How can they reflect critically on the assumptions, values, and biases that underpin systems of care? And then how can individuals, not just those with structural power, but everyone in a team, explicitly reframe situations to highlight structural components and role model that for others? In our research, we found that role modeling and doing so with confidence actually served as a social reinforcement for change within clinical learning environments. So under critical reflection, really questioning those assumptions. What is care? Is it care for the whole person, or is it a medical model of care that's reductionist and essentialist? What words are we using, and what systems of power do they reflect? What are the discourses in our conversation that reflect our power versus seek to share power in a more egalitarian and democratized way? Reframing, getting out of dichotomous thinking. When we see a problem, is this a patient or is this a person? Is tension something we should be afraid of and avoid, or is tension something necessary and productive for more humanistic and dignified care? And is power something we need to hold and be afraid of sharing or seek to gain through coercive practices? Or is power something that should be viewed as dynamic and shared? What about behavior? We found this commonly. People would become agitated, the term behavioral would be used. What does a behavior do for a person, for a system? How does it give relief? How does it help regulate? How does it help feel connected and with a sense of purpose? A lot of this falls into the framework of trauma and violence-informed care, shifting the frame of what we do from what's wrong with you to what happened to you, normalizing and validating that we are all, both those who seek care and those who work in the system, flawed, imperfect human beings that can strive to be better, but must at the outset accept that we will always stumble along the way. And that's where the last piece of our research I want to highlight for you really makes a difference. And that's recognizing this for ourselves. We cannot draw from our reserves if we're perpetually in the red zone ourselves. Self-compassion, we found in our research very clearly, is a crucial ingredient for addressing stigma and bias and providing high quality compassionate care. I can't go through all of this in detail with you today because my time is up, but I did want to cue you to a resource we developed called sharedhumanity.ca. It's a framework for working through how to get out of some of these coercive practices in such environments. If you go on the website, there's a health professional tab. There's some modules that I encourage you to check out and see if they might be useful to you in the work that you do. And with that, I will stop for questions. Hopefully right on time.
Great. Thank you, Dr. Zukera. And if anybody has questions, just a reminder to please type them in the Q&A field, and we have a few minutes reserved for you to ask your questions. Okay, it looks like we've got a couple questions coming in. Dr. Zukera, are you able to see those in the Q&A function?
Yes, I am. So a couple things. First is about the removal of a violence flag in hospital as a reality. This is a topic I've had quite a bit of conversation about in my new organization. I do think that an ideal state would involve no violence flag. That would be what to work towards, because ultimately it would be about being better at identifying and stratifying risk in a much more humanistic way. I don't think that that's necessarily something we can do right away. We look at the evidence on violence prevention programs. There is evidence clearly that a much more trauma and violence informed perspective actually enhances our ability to create safety within a workplace. One of the key features, though, is if you just implement flagging, it actually leads to an increase in incidents of workplace violence, which is why any flags have to be implemented concurrently with structural reforms that enhance staff safety, as well as training, particularly on communication skills. The other piece is patient ownership. So just to give you a window into my world, I moved from Canada to the US. Here, under legislation, all clinical documentation is accessible to patients. They can read every note that every physician writes about them in the system. And so any flags that might be implemented in a hospital organization should therefore follow the same principle. They should be implemented transparently with ownership and agency for people who are seeking care, and transparency around different types of policy. It should also not be permanent, given the dynamic nature of things. And it should be implemented in a way, the same way that an alert comes up, for example, if someone's labs are too high, that this is a flag to help identify ways to provide better care, to engage in conversation, rather than a label like a scarlet letter. Do you get pushback is a question? Absolutely. One of the biggest barriers to this sort of thing is unions. And so I do think we need to have a more collaborative conversation about how we work together, particularly centering the needs of the people who are seeking care. Again, that kind of dichotomous thinking can get us into traps. And sometimes employer or professional-based organizations for any profession can tend to view things much more centered through the lens of that profession, which of course we understand and appreciate. But what we also know is it doesn't have to be in a zero-sum way. In fact, disrupting zero-sum framing is a key ingredient in equity work. There's a point around people being burnt out and fed up. Absolutely. If people are burnt out, or if they feel that they're not protected by their organization and that their organization doesn't have their back, they're going to function in a trauma-based way. Their frontal lobe is less likely to be engaged. They're going to have a harder time, thinking more metacognitively or seeing nuance, because they're going to be functioning more in fear mode.
Okay, great. Thank you again, Dr. Zukera, and thanks everybody for posing your questions to the Q&A field. We'll move on now to our next speaker. Mr. Gord Gardner, is the Vice President of Strategic Partnerships of the Community Addictions Peer Support Association and the Chair of the annual Recovery Day Ottawa event. He is a national public speaker and trainer on addressing stigma and person-first language. He is living well with his own substance use at the time of providing us information for his introduction today. He is dedicated to removing barriers to enable policy writers, academics, researchers, and people with experience using substances to take evidence-based actions to improve the lives of Canadians. He advocates that the Health Canada 4 pillars should be changed to all serve one purpose: increase substance use health for Canadians. This naturally leads to advocating for and creating change. All Gord's work is informed by his 38 years of active addiction and by those who helped him along the way. So without further ado, I will hand it over to you, Gord.
Thanks, and hi, everybody. And I really appreciated the last presentation. It's not often that I have a chance to hear a presentation on stigma. So thanks for that. I wanted to set the screen here today, if I can. Was saying a couple of things right off the get-go. Number one, isn't this tremendous that these organizations have gathered together and worked for the last couple of years on making a life better for people who use opiates, addressing changes in the system, identifying the need. So I just want to give a lot of respect for that. I was actually one of the early committee members. CAPSA, the organization that I work for, is funded as the only national organization that's funded strictly to work on stigma and discrimination towards people who use substances. And so that includes everybody for us. And because we were a smaller organization at the time, I had to remove myself from the committee and focus on the broad population. But I'm really glad the committee continued its work. And I'm really pleased to be here today. And I guess what I'm going to do is put a little flag in the ground for how to continue on in this work. And I want to just take a look at the people we're not talking about today.
So many of us are walking alone in our grief over losing someone to substance use. Blinded by sorrow and silenced by stigma, it's hard to find others who understand our pain. We don't talk about our loss as much as we would like, because we can't. People view death differently when it's a result of substance use disorder. There is still so much stigma. If only people knew that substance use disorder is a health condition and that addiction is not a choice, they might have more compassion for us, the grieving, and for the 60,000 people we lose to substance use each year. Each death represents 7 grieving family members, friends, neighbors, and coworkers. We are nearly 500,000 Canadians looking for answers and meaningful action to prevent more deaths. So let's walk together in compassion to honor those we've lost, to help end so much needless suffering, and increase wellness for all. We know we can do better. Let's do better together.
So we want to recognize, as we saw earlier, that about 27,000 Canadians died from opioid overdose in the last 5 years. And I just want to draw attention that 250,000 other Canadians died from other substances in the same period of time. You won't see anything in the newspaper. There isn't any focus on education, on changes in the system. There isn't a discussion about that. And so I just want to recognize, even as we work to help those people suffering from opioid use disorder, our silence on the other issues is in fact stigmatizing, is in fact system level stigma. And that silence is killing people. And so, as Joy says, I am about the work that's being done. I see all the work that's ahead of us. And I know that this group is very sincere and interested in the health of Canadians around substances. So I want to show you some other information we're working on that's going to support your work and your efforts going forward. So substance use health, how to move forward into wellness. We speak about health because it's the common thread Canadians seek for themselves and communities. Substance use can be beneficial or safe, with many people using substances to increase their health. A continuum of a person-first focused outcome includes supports across the continuum of substance use health. We see this here, that some people don't ever use substances. Some people use substances and don't use them anymore. People often use them for benefit, for social effects, or for ceremony. There's lower risk, occasional use that has negative health or social effects. There's problems occurring, use that has negative consequences for individuals, families, or communities. And then there's the final end of the spectrum, substance use disorder, diagnosable chronic medical condition based on 11 criteria listed in the DSM-5. And so we know that 80% of Canadians will use a substance next year. And yet, we keep talking about this small percentage on the right-hand side. I happen to be part of that percentage, but it's a very little piece of Canadians' experience around substance use. And so how come they can't talk about their substance use health? So our vision is to create equity for substance use health, resources and funding to advance equitable care across the continuum. When I say physical health, you do not assume that I'm at the emergency room of an appendectomy. When I say mental health, you don't immediately think that I'm having a psychotic episode. You may think I'm jogging around physical health. You may think I'm doing some meditation exercise. You may think I'm feeling some stress, but you don't go to the far end of the spectrum. The idea with substance use health is it stops that connection with substance use with illness and stops that prejudgment on the person. And it's a reality for Canadians. As I say, 80% of us will use a substance next year. Right now, what we have is stigma sits on top of prevention, treatment, harm reduction, enforcement. And of course, health and human rights and evidence gets held down instead of lifted up. The next stage is that we put wellness on top. That's going to allow people who use substances or have substance use disorders or are struggling with substance use within those pillars to come out and say, we don't have to go look for lived experience. We're already in the building. We're already working in enforcement. We're already working in harm reduction. We're already working at treatment centers. We're working at prevention. We're a part of the community, not separate. And you end up with this wheel. There's all kinds of evidence that shows that a more equitable society increases the health of people long-term, and particularly increases the health of people around substance use. Free education around the concept of what substance use looks like, what healthy use looks like, what it looks like when it's problematic, would be normalized. And of course, we would have supports for increased health around substance use, no matter what part of that continuum people were on. And then we'd have supported regulations around supply. And I'm going to stop the share here now. So hi, everybody. I can't see anybody. So I have to believe at least a few of you are listening to me. And I just want to do a couple of things around language, if I can. You know, we all take pronoun training here at CAPSA so that, you know, we have some sense of what to do. And I love the presenter because Cameron always says to me, you know, Gordon, if you get really confused, you can always call me Cameron. And so when we look at language, if we get really confused about person or client or patient, you can always just say Bill, Sally, you know, just call us by our name. So I have a little show. I got to take off my backdrop for a second so I can do this for you. Sorry about that. So what is language all about? There's some evidence that says that if you try to describe someone as a substance abuser versus someone with a substance use disorder, that all of a sudden 67% of people believe that that punishment's now required. That's how strong language means. Here's the really sad thing. Even if you use medical terminology and says someone has an opioid use disorder, 24% of people still think punishment is part of the answer. We have this long-standing belief that if these people have suffered the consequences of their action, then they would stop. We utterly forget that the diagnostic criteria for substance use disorder is that consequences don't stop the behavior. That's why it's a disorder. That's what's diagnosable. That's what the problem is. It's not the solution. So here we go. So here's the person. Substances and behaviors. When I talk about their substance use and I talk about their behaviors and I see them through that lens, I can't see them anymore. Can you? And now that I've taught them to call themselves names and to label themselves, and they see themselves through their substance use and they see themselves through their behaviors, we're both at the same place, talking about what has been, not what might be. If I talk about the person first, the substance use and the behaviors may not change, but as a person, I have a lot more empathy and compassion for people than I do sometimes for behaviors, inanimate objects. We want to have person-first language and all these things. We want to use language that's non-harmful. And we want to realize, as Ann Bishop says, that if I'm not actively working against the oppression of others, then I'm part of the oppressing class. That's always a difficult message for health system workers, because obviously people are interested in other people's well-being. They've gone to school for this purpose. They dedicated careers to this purpose. So what we like to think is that we have an ignorance problems. We do not have a care problem. And so once we have more education, more resources, we will shed our ignorance. And so I always like to open the door around that. Just to let you know, it's a little awkward sometimes when you look up and you realize you maybe have been hurting people you're trying to help. And so as a young person in small town Ontario, I grew up and I moved to Ottawa. And I worked across the table from the first gay man I ever knew. And I looked him in the eye and I said, oh, there weren't any gay guys at my high school. And he laughed and he laughed. And eventually I figured out he was laughing at me. And then I remember blushing. I had this overwhelming sense of self-disappointment, perhaps even shame. I realized that my language about gay men in high school had been harmful and cruel. The people I'd gone to grade 1 with, I'd known all my life and thought of as friends. And I didn't even know who to call and say sorry to. You know, and we heard earlier the word that we need to be compassionate with ourselves and compassionate with others. If this man hadn't been compassionate with me and willing to see me as ignorant, he didn't see me as someone who wasn't harmful. I had absolutely harmed people. He saw me as someone who's ignorant, who could be taught, and he did teach me a way to be respectful and meaningful and stand beside people instead of separate myself from them. I'm very grateful for that. That's what CAPS is all about. We're here to help. We're here to help make change. And the reason we're here to help is because people aren't doing it right. So that's a difficult message. I hope that I've carried in a meaningful way today. I want to go back again to the work that's been done and give my thanks for that. I have lost personal friends to opioid overdose. I've also lost friends to tobacco smoking and alcohol and other substances. And so all those lives are very important to me. And I'm so glad that we're doing this work. And thanks for having me here today. I hope I haven't been too long-winded.
Thank you, Gord. Some really powerful messaging there, and we really appreciate you presenting to us today. We do have some time for questions, so we're going to give it a few minutes for people to pose their questions into the Q&A function.
Well, I feel I should notice that some people are saying some nice things in the chat, but maybe, you know, I'm glad to answer questions if anybody has any. Can I tell you a little vignette then? Is that okay? Do I have time for that?
Yes, of course.
So I was fortunate enough, I was able to take a police officer with lived experience to the United Nations Drug Commission last year and work at the Canadian booth there on stigma. And, you know, he was kind of the hit of the thing, eh? You know, here's a police officer. And I said to them on the way back on the plane, I said, well, you know, I know you think you got it tough as a police officer struggling with your substance use, but geez, you should see what the nurses go through. And so I just want you to know that now we're working with nursing here through the Canadian Nurses Association and a whole bunch of different peer groups on nurses on how come they're not allowed to struggle with substance use without having their livelihood threatened and accessing resources. So when you think about stigma, let me tell you this story. So today in a difficult part of town, 3 homeless people got together and said, if we hustle together, we could get money for a bottle of 10, but if we hustle individually, we won't make it. And so they work together and they get common cause and common purpose, and they get the money and they get the bottle and they all have a drink, and there's a moment of victory. Today, in a really wealthy end of town, someone with all kinds of bottles and substances and money in their wallet and kids in college and a car in the laneway and a partner had no one to talk to about why the comfortable chair offered no comfort. So who's more lonely? Police officer, the nurse? These are the questions we need to ask ourselves. And I've been homeless, so I don't get me wrong, indoors is good. Anyways, I have been going on for a bit. There's no questions. I think you should kick me out of here.
We won't kick you out, Gord. I think people are just enjoying listening to you speak. There is actually one question in the Q&A field asking if you're available as a guest speaker for nursing programs. So is there information you can provide about how people listening to the presentation today can follow up with you?
Oh, I think you're muted.
Somebody's dream came true. I'll put my email address in the chat box here for everybody. And as an organization, we're very glad to do that kind of work. And so whether it's me personally or somebody from the team, you know, we're actually going out to Vancouver on Saturday to work with Equip Care at the University of British Columbia, which comes out of the nursing department there, and with some folks from Western University on equitable care through the lens of violence and trauma-informed care, but also through the lens of substance use and that intersectional piece.
Great. So for all attendees, Mr. Gardner just provided his information into the chat field. So certainly take note of his email address and follow up regarding speaker opportunities. Thank you again, Gord. We really appreciate your presentation. And time has gone fast this afternoon. We're actually, next on my agenda is wrap up of the webinar. So again, I want to thank all speakers who shared their knowledge with us this afternoon. It was a wonderful webinar. I'd also like to let everybody attending know that CAS and Office will follow up with an email that will contain links to the e-resource as well as a short survey on the e-resource. And we would certainly really appreciate it if you could take a few minutes to complete the survey. So thank you again to all speakers, as well as those who took time to attend the webinar this afternoon. We're very grateful for your participation. Have a great afternoon, everybody.